Thank you, Dr. Lee. Now that you've shared some of your tips and tricks, I'm going to share my application screen so that we can kind of walk through those techniques and dive a little bit deeper. I hope everyone can see my screen right now. So a couple of things that I want to go over first. If you were here for our educational portion, you heard that Dr. Lee likes to advance his needles with the needle holder at the hub of his needle. And then if you just saw his lung biopsy video, he's actually advancing the needle with the needle holder at the skin. So a couple different reasons to perform those different techniques. So the first one I'm going to go over is advancing the needle with the needle holder at the skin. So with this, Dr. Lee likes to use it for smaller lesions because you have less variable motion. The needle holder will keep that needle in a stable position. And he also likes to use this technique when it comes to a thinner gauge needle to avoid bending that needle. Remember, we are a linear system, so we want to avoid bending that needle so we can be as accurate as possible. Okay. The second technique that he uses is to advance his needle with the needle holder at the hub of the needle. So if you can kind of see my application screen right now, the slightest bit of movement with this up here is going to completely change your trajectory. And so when you're advancing this way, Dr. Lee's technique is to kind of use this for a larger target because you do have more variable movement when you're advancing your needle this way, and to also use it with smaller gauges. So he uses this for a 17 and 18 gauge. So that way he knows that he's not going to bend that needle and he can continue to advance this way. So this is going to kind of take me into a second technique, which is asking yourself the question, what are you worried about? When it comes to Dr. Lee's practice, he only does his check scans around critical structures. He likes to say, don't waste your time in muscle or non-critical structures. Instead, focus on what you're worried about, and then that's when you can perform your first check scan. So when it comes to placing this needle, what we're going to do is we are going to find that trajectory. And if you take a look, and I'll zoom in for you to see, it looks like we're about 5 centimeters deep before we even reach that kidney. So what I'm going to do is I'm going to show you a completely off trajectory, somewhere that we wouldn't normally go to target that adrenal gland. And I'm going to advance 5 centimeters. Okay. So now what I'm going to do is I'm going to slide this needle holder back up to the hub. And as you can see, I haven't overshot, even though my trajectory is completely off from where I would normally want to go. And this kind of demonstrates that you're never going to overshoot. So you can really advance that needle as long as you use the correct usable length and insert that into the needle portion of the Amactus system, then you'll be fine there. So what I'm going to do is I'm going to now take this needle out, and we're going to actually try to hit that target. So here again, advance those 5 centimeters. Take a look at that depth. So we now know that we're not going to injure that kidney. Here, if you wanted to convert to CT fluoro, then again, we have this tool on our sagittal view to let you know exactly where to place your table to find the tip of that needle. Or if you wanted to do a full check scan right here, then you could. Another point to touch on, Dr. Lee had mentioned, if you use your most updated series, then you will be the most accurate that you can be. Okay. The next point that I kind of want to go into is how to adjust your needle. So a trick that Dr. Lee likes to use is he likes to make an incision in his skin. Is right off the bat, if you're trying to push a needle through tough or thick skin, it may throw your trajectory off completely immediately, so that from the beginning, you're set to go into an opposite direction. So when it comes to adjusting your needle, remember we are a linear system. If you were to kind of torque your needle right now and push from the position that you're in, there's a potential that you could bend that needle. So his advice is to pull that needle back before you reinsert. And sometimes he even goes as far as to pull it completely out of the skin and then realign his trajectory from there, making sure that he is not bending that needle during his actual insertion. Dr. Lee, is there anything else that you would like to add to your tips and tricks and techniques?
Yeah, I just want to amplify some of the things that Sally just so eloquently said. There are two ways of inserting your needle, as she mentioned. One is to have the sensor at the hub, so it's back, at the back of the needle. The other is to have it at the skin. And I will do both ways. As Sally mentioned, if you're going to have it at the hub, then it amplifies small motions. And so it can be a little disorienting sometimes if your hands aren't super steady. The CT's moving a lot and it can be a little disorienting. However, if you do have the sensor at the hub, then the needle tip position is very accurate. And so with a stiff needle especially, I prefer to do it that way, especially for larger, simpler targets. If when you have the sensor at the skin, the tip position is not accurate. It's not that it's not accurate, it's just that the system is telling you that if you fully insert the needle, where your tip is going to end up. And so, but it also tends to hold the needle steadier. And so for smaller targets and for smaller gauge needles that tend to bend too much if you're pushing from the back of the needle, I tend to have the sensor at the skin, as Sally has right there. So that's exactly what she was saying. The other thing is that, as Sally mentioned before, one of the advantages of the Imactis system is that you can avoid having to do a lot of check scans updating your position when you're not in any critical structures. So there's no reason to take an extra scan when you're in the skin or you're in the subcutaneous fat or in the muscle, things that aren't super critical. So you can put your needle down very quickly to just short of where you're starting to get worried. And that's where I usually do my first check scan. And she showed you how she put the needle down just short of the kidney before she did the first check scan. And that you can save a lot of radiation and time for the patient and time for you. Lastly, just to amplify a few things that Sally said about repositions, as I showed in that video just a moment ago, my original position, my placement wasn't great. And that was mostly because the patient had 10 centimeters of fat and muscle to go through. And I was using a very long, small gauge needle. And so the needle was bending a little bit. And what happens is that if you try to make subtle corrections as the needle is advancing, as you might with CT fluoroscopy, you're not going to be super successful because you can bend the back of the needle and yet the tip doesn't change position very much. And the system is predicated on a straight line from the back of the needle. And so if you bend the needle, then the accuracy of the system goes down. So in general, if you're going to make a recorrection, pull really far back, let the needle be very straight, and then try to place with a single movement following the natural trajectory of the needle. If you're fighting the trajectory of the needle, if the needle wants to go superior and you're trying to pull it inferior, the accuracy is going to decrease. So, so those just to amplify a few things that Sally had mentioned. We got a question earlier too about respiratory compensation, and you heard me mention that in the talk just a moment ago. And there's different ways to do that. The system is not designed to actually give you respiratory compensation, which I think is no problem because none of us really use respiratory compensation in our practices on a daily basis for a lung biopsy. We compensate by looking at the degree of inspiration when we place our needle. And in our practice, we place needles in the chest under free breathing. We let the patients breathe. but we do the setup scan in end expiration, and then we do all of our needle movements in end expiration, so we know that it's going to be accurate. We don't do any particular compensation. I don't have patients hold their breath. I just watch them breathe and only put the needle in during end expiration. And I know that when I do that, the system is accurate. The setup scan and when I'm placing my needle are going to be the same during end expiration. I find end expiration is the most reproducible phase of respiration. I think it's far superior to having patients hold their breath. If you ask people to hold their breath, it's very unlikely that they can hold the exact same breath multiple times, I think. And also end expiration is the longest phase of respiration. And so I think it's the easiest and you have the longest time to make your corrections. My nurse, Marcia, is incredibly good at watching people breathe, and she actually cues us when to move the needle, because sometimes when people are sedated, it's hard to see what phase of respiration they're in, but she's really good at it and helps me quite a bit during some of those procedures. So that's how I tend to do it in the lung. Okay, if there are questions, I'm happy to answer them. Sally, I'm not sure how you want to do the question and answer session. Are there questions coming through to you?
I don't have any questions right now.
Okay.
No, I would like to ask you, if you're starting to use the CT navigation, what would you say your number one piece of advice would be for, say, a brand new Amactus user?
Yeah. And I mean, we're often asked about how many cases you might need to do to feel comfortable with the system, that sort of thing, and how long it takes you to feel really comfortable and confident using it. I think this is different for everybody. I'm maybe old, and it takes me a little longer to pick up on some of the technical things. And so I would say that I was able to use the system just with one or two cases. We have Marion is our application specialist, and she walked me through doing the first several cases. And we were successful and able to use it very early because it's quite intuitive how to use it. But I would say by the time you've done 10 to 15 cases, you really understand what the system can do, and you're more confident at it. At least that's what it took me to feel like I was really confident and comfortable with using it. Previn, do you feel the same? Was it about that for you? I know it's different. You're so young, you probably picked it up in 2 cases after all those video games you spent your youth playing, right?
It's just the makeup. It's the makeup. It's just the makeup. Yeah, I mean, I think it's a very simple system to use. Before we first used it in Liverpool, like with all technical things, I kind of thought I was very conscious of the technical elements to it. And I think that a lot of the questions that have come through this afternoon have been about how easy it is to use. And I have to say that just from, even though I am quite techie, I have to say that I think the setup time is exceptionally quick. And it's quite important. I think it's quite relevant when you're talking about CT guided interventions and these navigation systems. That, I mean, this isn't the only navigation system, obviously, that has been available on the market. But I have to say, out of all of the ones that we've used, it is by far and away the easiest to set up. And the important thing, I think, for CT navigation like this is that if it's easy to set up, you're going to use it more, you're going to use it more frequently, and then you're going to get better results. And I think that that cannot be underestimated, that the setup time is so simple, it's so easy to do. And I think some of the presentations have demonstrated how easy it is to do, that I think that it's something that you are very likely to reach towards when you're doing your cases. And I think that can only be a good thing.
Yeah, I think that's an excellent point. My partners will tell you that I'm not super technically oriented, and even I can use this system, which is saying something. The other point that we had discussed earlier too, and I think you probably agree with me, Previn, is that if, and we mentioned this before, if you only pull the device off the shelf when you're in trouble, or if you have a very complex situation that you're trying to get yourself out of, that's not a great strategy, I think. In fact, I would say use this for some of your really easy cases, that 12-centimeter mass that's 1 centimeter below the skin surface, just so that you're super facile using it. It's not a foreign device. You don't struggle with it, and you gain a lot of confidence. I would urge people to do a lot of those kind of cases that you can, quote, I could do this with anything, because then you get through that learning curve very quickly, and you get confident.
I mean, I think it's important for to recognize that they're going to be different people are going to want to use the device for different types of practices. But I think in a practice where you're going to be doing a fair number of biopsies, as well as ablations or IRE or anything like that, I think you're quite right, Fred, that it is not a good idea to just be reaching for, even though it's very easy to set up. Your accuracy and your ability to get the best out of this device, or for that matter, any device, is always going to be better if you use it also for some of the cases that you probably could get by with just using ultrasound or whatever. And that's why I think that one of the things that I think is a very useful tool is don't just use it for ablations. So don't just say, well, I'm just going to get it out when I'm going to do a microwave ablation. Use it when you're doing a biopsy as well. And I think that that's particularly true in lung cases. So if you're going to be doing a lung biopsy, do it for a lung biopsy. And then when you're next doing a lung ablation, you're going to be a lot more comfortable about using the kit.
Yes, I totally agree.
One question I was going to ask both Sally and you, Fred, is what do you think the limitations of the device are?
Yeah, so one of the things that, like any technology, there are places where it's better and places where it's not so good. And as I mentioned in my presentation, the way I think about lung is that the higher in the lung that you are, the less motion there tends to be from the diaphragm, and the more accurate the system is. And also, the higher you are, the less you have to pay attention to the phase of respiration, because things just don't move as much. So as I move lower in the lung and the nodules get smaller, I think a little bit more about CT fluoroscopy, I have to say. The one thing where you can it's not in trouble, but where you can end up spending more time and need more check scans is if you have a really small nodule at the lung base, and you can chase that quite a bit. And I have to admit that with CT fluoro, it's probably more efficient to go after those really small nodules at the bases with CT fluoro versus with Amactus. But I would say that in the lung, I mean, I've replaced maybe 75% of my lung biopsies now I do with Amactus, and I think I'm a little bit faster with Amactus than I'm pretty fast with CT fluoro, but I think just the fewer number of scans and everything, I'm probably just a hair faster with Amactus, at least no slower. And importantly, I don't have to put on lead, and I get no radiation from the procedure. The other day I was doing cases with my nurse, Marcia, and we didn't put on lead the whole day. And that was a pretty nice, I didn't have all the sweat drenched all over me and all the stuff that you will with lead in a gown.
I think that's particularly important in the current climate, with the amount of PPE equipment that we're having to wear for patients that are under a general anaesthetic. So most public health services are recommending quite a lot of PPE and FFP3 masks, and for intubated patients, not having to wear leads is a real benefit, and shortening procedure time as well. I think is a massive benefit. It can only be a good thing.
Sally, do you mind just talking about placement of the fiducial for a moment? And because this sometimes it may not be quite as intuitive as you think, and just a few tips and tricks about where to place the fiducial and how to do it. This is something I had to learn from some mistakes that I made.
So we always advise you to secure your fiducial down with a Tegaderm on a bony or secure structure. And to just kind of speak on what Dr. Fred Lee was mentioning, one of the limitations can be that this may not be, Imactis may not be used for every single case, especially if you're under conscious sedation and your patient is moving a lot. That can influence the accuracy of the system. So even though you have kind of intra-abdominal movement, if your patient is moving a ton as well on the table, then that may be a limitation to the system during that specific case. We always advise either the sternum or the spine, bony secure structures. You can do the pubic bone or the hip bone. For instance, if we were to place the fiducial, say, on the arm, and the patient were to move their arm like this during the procedure, that would completely throw off your accuracy. You do have a 25 centimeter range from this fiducial to navigate. And so we kind of tell you to keep that in mind as well. You want to make sure that you are kind of within that zone. So once you figure out where your entry point may be, kind of that area of interest, that's when you'll go and you'll secure your fiducial down accordingly.
Great. Mm-hmm. One other comment I just want to make sure people understand, because this is something that that is a little different than the fusion systems. So with fusion, you generally will use a CT or MR or maybe a PET scan that was performed a day, a week, a month before you're doing the procedure, when you're actually in the procedure suite. And the patient may be in a position that's slightly different than the treatment position that you have the patient while you're doing the procedure. So that's one difference with fusion. The other difference that I think is really important is that every time you do a check scan, so you put your needle down to the pleura and you do a check scan, it refreshes the system. You send the images to the system, and it updates the system. And now you use the check scan as your new setup scan. And so it is, while it's not exactly real time, it's really close to real time. And if you think that the patient has moved a little bit, or you're a little unsure about where you are, just do a check scan, and the data is now refreshed, and so you get it very accurate. And I think that's something that took me a little getting used to, was the accuracy of the system, because the patient is in the position that you're doing the treatment. Previn, is it the same for you? Do you feel like, I mean, the updating of the system gives you a really nice baseline to work from then?
Yeah, no, absolutely. Yeah, no, I definitely endorse all of that, really. Sally, did you want to add anything else?
No, I think we're actually running out of time.
Okay. I think it would be a good time to say thank you to all of the presenters, but we've got Fred and Sally still with us, so I'd just like to say thank you to both of them for their excellent presentations. I think it was really helpful to see Imactis in practice, and I think for all of those who've attended this webinar, I think they would have really benefited from Fred's extensive experience of using this. And I don't think you could hear from better two people about this product. So and I think it's going to be a really, really important tool in CT guided interventions in the future, and it'll be very interesting to see where it goes as well. So thanks again to everybody, and finally thanks to BSI again, and to Imactis and to BVM in the UK for supporting this. And thanks very much, and hopefully see you all soon again.
Thank you.